With this, we move ahead to our next session, which is about teleophthalmology, about present and future. And for the same, to chair this session, may I invite Dr. Manoj Chandra Mathur. Welcome, sir.
Thank you, Ekta. It is my pleasure to be a part of this session on teleophthalmology. We have an international speaker, Dr. Hunter Sherwick from Virginia. And at the outset, is Dr. Natarajan here?
Yes, sir. So we do have our co-chairman and governors present. So with your permission, let us start with this session. You can invite the first speaker.
Yeah.
Dr. Subudhi.
Yeah, and
Dr. Natarajan to speak.
Yeah. He will join, I think he will join shortly, sir.
He will join shortly. So without further this thing, we will straight away go to our keynote speaker, Dr. Hunter Sherwick from Virginia. Dr. Hunter Sherwick is a global ophthalmologist with a specific career interest on how training and technologies can be used to eliminate avoidable blindness in low-resource communities around the world. Dr. Hunter, after graduating from Emory, he joined Orbis International, where he was able to lecture and work in over 20 countries abroad, the Flying Eye Hospital, and help build telemedicine and distance learning platform, www.cybersight.org. Dr. Sherwick is at present also working for Orbis International to continue to support its clinical training efforts and patient care programs as Vice President Clinical Services. It is my pleasure to invite Dr. Hunter Sherwick to give his keynote address.
Well, thank you, sir. That's a lovely welcome, and it's great to be at this conference. I've attended this conference 3 times before, but this is my first time virtually. I also, before I want to start, I just want to let you know that I'm sending good thoughts every day to India. I've been speaking to our team. Many of you know that Orbis has had an office in India for more than 20 years. I just want to let you know that every day I'm speaking with our team and my friends in India. My birthday is August 15th, so India is a very special place for me. I've had 3 birthdays in India and you all celebrate it wonderfully. So I think everyone knows Orbis. Obviously, we've been working with partners in India for a very long time. What I'm very excited about is that how our organization has pivoted during the COVID crisis to Cybersight. And I know that the subject of this title was teleophthalmology, to do or not to do. I think that was a Shakespeare quote. I strongly recommend those watching now, but also those who are watching the recording, please go to the website, www.cybersight.org. Orbis has been investing in teleophthalmology for over 18 years. And I'm very proud to say India is our #1 user of Cybersight around the world. Cybersight is in every country in the world, except for North Korea, Western Sahara, and Turkmenistan. So I'm very proud to see how we have been able to pivot and meet the needs of our doctors around the world through Cybersight. So if you want to take a minute right now and just go to cybersight.org, I also recommend that you register. You can go on Cybersight without registering. Everything is free. But if you don't register, all you can use is the library. If you register, you can also then use the courses and have free access to the consults. And I know today we're going to be talking about teleophthalmology, and I'm going to talk about how we've reimagined that concept during COVID. Can everyone hear me okay? I just want to make sure I'm
Hello?
Is everything clear?
Yeah, you are clear.
Yes,
Okay.
It's clear. It's clear. Please proceed.
Okay. Yeah. Okay.
Your voice is clear.
Okay,
Yes.
good. So again, one of the things I would say, a lot of people view teleophthalmology as just the linking of 2 doctors to discuss a case. I'm going to talk about how teleophthalmology now can connect a residency program and also connect an operating room. So we all know that by public health numbers, the world's number of patients who are visually impaired is set to triple by the year 2050. So we must be looking for scalable solutions, not just for doctor and eye health professional education, but also patient education. And our solution at Orbis is Cybersight. Cybersight, I'm very pleased to tell you, will be launching an app that will also be freely available to the world starting this summer, probably around August. We're putting the final touches on that app. So please be following on cybersight.org. We have done over 21,000 consults. Most of these are in pediatrics or in subspecialties. For example, retinoblastoma, we have linked over 950 cases of retinoblastoma with experts from around the world. This is not a grandmother asking a doctor about her grandchild. This is an expert speaking to another expert about a very challenging case that they would like a second opinion on for free. You can see that already in 2021, our numbers continue to grow, except for consults. And a lot of this is because many of the hospitals are slowing down due to COVID lockdowns and the decreased footfall of patients through the OPDs. Again, under the library, I strongly encourage all of the AIOS members to please look at the library for videos, books, lectures that are of interest to you. We are the #1 largest website for freely available educational material around the world. One of the things that you will have to register for, so if you're on the website cybersight.org now, you will need to register to have access to these courses. They're courses for not only doctors, but right here you can see a course for technicians on how to do fundus photography. As I talk about artificial intelligence next, the quality of your AI is going to be largely based on the quality of the images you submit. If the image is blurry or if there's a lot of motion artifact, the AI will not be able to do its job. So know that we have courses for nurses, engineers, anesthesiologists, residents, trainers, as well as subspecialists. Every week we have webinars, and they can be on live surgery. They can be on, for example, glaucoma or hospital accreditation or COVID. And this is what I'm most excited about, how Cybersight now has made artificial intelligence freely available to the world. You do need to register. You do have to submit your diploma to show that you are a physician. But what we're able to do now is take a submitted retina photo and not only look for diabetes, which other AI platforms do. I believe we are still the only platform that is also looking for macular disease, macular scars, macular edema, macular degeneration, but also the optic nerve, looking at the vertical cup to disc ratio, as well as the disc margin, looking for papilledema, disc edema, etc. I would say that one of the things I like about the platform, it is not black box autonomous AI, where the AI says refer, not refer. It actually walks the doctor through the algorithm and shows all the pathology. And then this case is discussed with a human grader within 24 hours. We are doing large clinical trials around the world, including the largest trial in ophthalmology in Africa, in Rwanda. I'm very pleased to say that we have 50 more patients to enroll, and that data will be available this year. If you're interested in AI, either about Cybersight AI or the field of AI, we have many lectures on the webinars on Cybersight for AI. And I recommend that you look and take some of the prior lectures and look at how we are using AI, not just for patient care, but for residency teaching and subspecialty care. I mentioned how we're reimagining teleophthalmology. And one of the things that makes me very excited is how we've linked training centers around the world. For example, this is the Dr. Yusuf Khalifa at Emory in Atlanta, Georgia, and he has been linked to a residency program in Peru where all the residents go through the same curriculum. He reviews all of their surgical videos. He gives them the follow-up details. They have to pass tests so that when they get to their operating or OT experience, they've already done literally dozens of hours of lecture, video review, as well as hands-on training. And then we've taken this to the extreme where we're now connecting a doctor live in the operating room with an expert in another country. For example, in Cameroon, this is a doctor, his name is Dr. Ted. He actually went to India for part of his hands-on training, came back, and then continued to work with Dr. Larry Benjamin based in the UK. This model has been published, as you can see here, with our partners in Peru, but it is very exciting to see how we've reimagined teleophthalmology to help education, to help patient care and consults, and to help doctors in the operating room as they move to new techniques like phaco or pediatric cataract. One of the things I would also say, and for all of those who are interested in residency training, I believe we have the largest and freest available simulation manual that is in the library. So if you are looking at building a wet lab, especially during COVID, so that residents can continue to get hands-on training, I strongly recommend you look at this simulation manual. So again, I want to end this lecture as I started. I certainly want to leave time for questions. I want to end by saying thank you. I really appreciate the partnership that we share with the Indian ophthalmic community, both as Orbis and Cybersight. Our number one user for Cybersight is India. We use professors and academic greatness around India, the north, south, east, and west, for webinars, for courses, and consults. If you are interested in learning more about Cybersight, please let me know, or simply go to cybersight.org and register, and then we can start helping you one-on-one with our team.
Thank you, Hunter, for a wonderful talk. And as
Thank you, sir.
Thanks for joining us. And I'm sorry I was a minute late by the time you already started.
That's okay. I know you were pressing your suit. You look very well dressed, sir.
Oh, thank you. Always. I love to do that. And I actually dress to kill.
All right.
Yeah. So, Hunter, as I asked, I think we are already, as a president of Teleophthalmic Society of India, with Dr. Subudhi as secretary, yes, and Dr. Sabyasachi as treasurer. You are one of the keynote speakers there, and also in All India Ophthalmic Society. So my request is, as I said, I want to teach 3D surgery through Cybersight. You said you are doing between US and Mexico. So maybe I would like to have a one-on-one session with you. You as my teacher, and I am a student.
I never say no to you, sir. And again, I would say for
after finishing the conference on Sunday, maybe after that I'll ask Shubha to write a mail and we can do a setup. And in case Subudhi and Sabyasachi or anybody who like Rajiv like to join, we will have a one-to-one. Is I'm student and Hunter is my boss.
We are students.
Yes. I am enjoying the Cybersight. I keep logging in, and I also told all the doctors associated with me, as well as the members of the Teleophthalmology Society of India, and whether we can officially take part. I think it's beyond this meeting. So I think I also, because I think it's maybe too early morning for you, and I think Dr. Manoj is here. Any questions to Dr. Hunter? Because we already had an interaction with Dr. Hunter before, and I'm active participant of Cybersight, and I actually like to teach the 3D, which I'm going to do in future. So Manoj, do you have any questions?
Thank you. I would like to thank Dr. Hunter for this enlightening talk and enlightening us about the cybersight.org website. We shall certainly visit and get in touch with you for any of our requirements. And just now I got a bombshell from the scientific committee that we are supposed to wind up the session at 5:25 and not 5:55. So 5:30.
So let's just move forward with the talk. Otherwise, we will miss listening.
Yeah. So Manoj, I'll only take 30 seconds as President Teleophthalmic Society. That I'm grateful to the scientific committee and ask you people to take over so that we don't waste time.
So the next will be a very brief introduction by Dr. Natarajan, and followed by our regular didactic talks. Probably depending on the time, I request all the speakers to stick to their time. In fact, reduce their time a bit so that we can squeeze in some sort of a panel discussion. 5:30 is the inauguration. I think at least by 5:40 we should be able to wind up our session. And
the halls will have to be stopped by 5:30, and the AV people will also stop the presentation. So I will request you to end by 5:25, so we all can attend the inauguration.
Okay, let's start. We don't delay. Let's start with the. So there are couple of very good talks which are lined up, and we start with Dr. Prem Nandini from LV Prasad Eye Institute on a very important thing. We want to connect the real world with the virtual world. How we can do a virtual visual acuity testing in teleophthalmology. Prem Nandini, please.
Thank you, Dr. Rajiv. I hope my slides are visible.
Yeah, they are visible.
Yes.
Okay, so this is the data that I'll be presenting for today's talk essentially comes from a collaborative team effort of optometrists and ophthalmologists who are displayed here. I'm going to try and whip through so that I can stick to the time. As always, any pandemic brings all these stages of grief, and it's no different for COVID-19 also. But as healthcare professionals, we are in the acceptance stage and we are moving forward to adapt to the changing times. And one of the things is actually to move on to teleconsultation, teleophthalmology. So this is a survey that AIOS did exactly 1 year back. And we can see that 99% of ophthalmologists are interested in trying out mobile app-based teleophthalmology. Now, while there are different types of visual functions out there, the number one that we always focus on is visual acuity. So you may have color vision, contrast, etc. But we generally tend to give a primary focus for visual acuity, be it for the surgical success or for prescribing your spectacles. So if I type in visual acuity and teleophthalmology as the keywords, and this is some search that I did like a couple of days back. And if I simply say since 2020, how many articles are out there, you'll be surprised that literally about 20 papers per month comes out. And I suppose Google also boosts your ego by putting out your own paper on the top. So while before I actually talk about this study, which is primary focus of my talk today, I would actually like to take your attention that in terms of visual acuity testing, there are sort of two modes of doing it. One is self-administered and the other one requires another person to administer it. So this is a study that came out in Nature in Digital Medicine. And this was, of course, done before the pandemic era. And what they saw was, while there are almost like more than 2,000 tools out there for self-administration of visual acuity tests, only 42 sort of fit that criteria. And the criteria is it has to be free or less than 5 pounds, and is there support and all of that. And even within that 42, there was only one that was validated against a gold standard. So clearly the tools that are just randomly out there are all not suitable for testing visual acuity. But then there are other tools that were specifically designed to be used by eye care professionals to test visual acuity. And a couple of that is the peak acuity and the smart optometry. So the study that came out recently is something where we actually validated these two apps in order to find out whether they are reliable for measuring visual acuity as a part of teleconsultation. So this is the outline of the study. And primarily, I'll just, as I said, whip through these things and then maybe emphasize on what we learned through this process. So the study actually was conducted in 3 phases. In the first phase, what we did was we did a survey real quickly last year around April or so, soon after the lockdown started. And we actually targeted at our own employees. So we had about 43 people who participated. Of course, this was all online. So we had almost about equal gender distribution. And we also had close to equal distribution for clinical people who are already in eye care. They know what an acuity is, and also the non-clinical people. And the majority of these people were using the Android telephone. So we had asked them to install the smart optometry app and see if they can actually run the test by themselves as a self-administered test, and then rate and tell us how they felt about it. So majority of them said that it was definitely easy to install, and the instructions that came with the app was fairly clear to them. So this was encouraging that we could actually probably administer this test, as a part of the teleconsultation. So the next phase of the study was to now validate the tools. So for this, we actually validated the smart optometry, which primarily gives you the near visual acuity, and also the peak acuity, which can give you the distance visual acuity against our clinical standards. And our clinical testing is the computerized visual acuity chart that we use in the clinic. And because peak acuity comes with the tumbling E optotype, we decided that we will choose the tumbling E as the optotype for all the tests. So that way it becomes easier for us to compare each of these tests. And not only that, tumbling E can cut down your educational barrier. It can be used in children, and it can also be used across different people who speak different languages. So that was the good advantage over there. And this flow chart out here is actually showing you the protocol that we used. We followed all the COVID protocols. We first tested non-clinicians and then went to clinicians. And here are a couple of pictures. This is the examiner showing the peak acuity, and this is the smart optometry. And both these were installed on a tab. And as you can see, the tumbling E optotype is presented there at 40 centimeters. So coming to the results, what we find is peak acuity definitely correlates very well with CompLog. The smart optometry, on the other hand, when we are comparing it to the reduced Snellen near vision chart, seem to show significant difference. And when we compare based on the age, young and old, we find that younger participants seem to have a difference. And also in terms of refractive error, the emmetropic people seem to have a difference. And these are the lines of limits of agreement, the Bland-Altman plot. And we also did repeatability, and peak acuity was more repeatable when compared to smart optometry. So the recommendation is peak acuity correlates very well with the clinical measurements. Smart optometry does correlate too, but we'll have to know what the limits of it are. The disadvantage with peak acuity is it would require another person to test it at 2 meters, but nevertheless, it can be taught. And this is an unpublished data. We are working on the manuscript now. And what this tells us, these are real patients who were shown an educational video of how to use peak acuity. And they measured it by themselves. And then we compared that to the clinical measure done in the clinic. And it seems to correlate pretty well. So this is encouraging. And this is the rating for the app given by the participants, the patients, and the majority of them were finding it easy to use this after we showed them the instructional video. So that is all I have. I hope I stayed within time. And thank you for your attention.
Thanks. Beautiful talk. And I think the take-home message is very clear. Just one question before I go to the next topic. Do you feel the ambient illumination and the illumination at chart, and many of these depends, like many things also depends on the tab or the phone you are using. So what would be, because people have now so many apps and they tend to use it on any of the digital device. What do you feel about it?
So because these are all self-illuminated devices, so in terms of the ambient light, it should not have much effect. And the other thing is peak acuity and smart optometry comes with its own calibration, and they automatically set the brightness to 100%. So most of that is taken care of. And peak has actually been employed out in the fields also in Africa.
Correct.
And so
no, even in India, in our Smart India study, we have used only the peak acuity. I think it works pretty well.
Yeah.
Thanks. We'll go to the next talk, and we have the head of the teleophthalmology of LVP, Dr. Padmaja, my good friend. She'll be talking to us on teleophthalmology in COVID period. Padmaja. You are muted, Padmaja, I think.
Yeah.
Is
my slides, am I audible now?
Yes, you are audible and your slides are visible.
Yeah. Okay. Thank you. Good evening. At the outset, I would like to thank AIOS and Teleophthalmology Society of India for providing this opportunity. COVID pandemic has given an opportunity for teleophthalmology to rise, and it is actually healing from a distance. And there is a lot of enabling environment has come in the form of HIPAA restrictions have been removed, and specific telemedicine guidelines enabling telemedicine were introduced by the government of India. And it also recommended mandatory certification by the doctors practicing telemedicine and development of various subspecialty specific guidelines. Various institutes responded to the COVID pandemic proactively. Shankar Netra reached over 11,000 patients through teleconsultations. They also initiated an optometrist-assisted teleconsult model. SN tied up with Titan optical stores wherein a comprehensive eye exam, including imaging, was performed by the optometrist, and teleconsult advice was provided by the specialist after reviewing the reports. Aravind Eye Care System immediately launched teleconsultation as a solution to reach the patients. They developed a quick fix video conferencing solution using Google Meet to create platform wherein patients could access to doctors directly over the video conference using their smartphone or computers. And they send this information over WhatsApp and other media for the patients to be aware of. Patients could log into the link in the Aravind website, and by click of a button, they could consult the doctors directly in any of their tertiary hospitals. And this was provided as a free service to all. At LV Prasad Institute, we were able to connect through the telemedicine across the pyramid. Nearly 84,000 teleconsultations happened in the last year across our pyramid. And during lockdown period, at the primary and secondary level, more than 100,000 phone calls were made by our vision technicians. Here again, the most important aspect was the fundamental tool which enabled this was a strong electronic medical record base, which is a foundation for any teleophthalmology system. 500 teleconsultations happened with the help of photographs taken by the rural population through the VT ophthalmologist WhatsApp group in the month of May. And this is a lockdown story in the second wave, actually, where for patient information received to the WhatsApp, care providers could send patient reports through the WhatsApp to the vision technicians in the rural areas, and proper advice was provided by the physician, which was integrated into the teleophthalmology electronic sheet. At the tertiary level, we had a sudden decline in the number of patients from an average of 1,500 per day to just 50 per day. We immediately launched initially a teleconsulting portal. Telemedicine achieved 3 significant objectives during the lockdown. One was triage, which patients need to visit the hospital on an emergency basis. Then second was management of medication and advice. And third, review of new patients, especially second opinions based on the review of images and reports. Recognizing the importance of teleophthalmology at the time of pandemic, we launched a mobile map app-based telemedicine portal, Connect Care. With this app, our doctors now can connect with the patients by clicking the button on their mobile phone or a laptop. All appointments are scheduled. It is just like a virtual outpatient OPD. The patient schedules an appointment using the application, downloads their reports, consults with their physician via an audio or video call. We also have a home care portal wherein our vision technicians in rural areas and optometrists in urban areas are able to reach elderly or patients with disabilities do the necessary tests, and a model of hybrid telemodel where the advice is provided by the ophthalmologist. The purpose of teleconsult portal post-lockdown is mainly to reduce the follow-up visits, and this in turn reduces the congestion in our waiting halls. And we made at least one surgical post-physical visit following surgery as a mandatory teleconsult, and this also helps us to maintain the social distancing protocols. Our consultants through this Connect Care app, around 30,000 consultations were able to be done in the last 1 year through this Connect Care app, and they could manage various eye conditions through the teleconsults, and cross consultation between the specialties were possible too. For example, this is the story of a mucormycosis where the primary retina consultant through teleconsultant could also cross the patient advice and report to oculoplastic consult as well, and could be given necessary immediate advice that is required. And power of teleconsults, removing the barriers of access because of the video communication, distance, and etc. This is a teleconsult from a train. Then diagnosing or looking at the triaging, whether it's like diagnosing a cataract or monitoring surgical follow-ups through the photographs captured by the caregivers. These are all endless possibilities. Then Silversight is a home care tele-innovation in teleophthalmology, reaching the elderly and disabled in both urban and rural areas. Telecontact lens practice is another innovative model in reaching the follow-up patients. And telerehabilitation is again a unique specialty where our team is gathering experience, reaching close to 1,000 visually impaired people. And these are some of the areas where our telerehab team is able to reach our clients through the early intervention therapy videos. For me to understand if she has good, and also they were able to reach the interactive videos to the clients in the form of early intervention therapy. And similarly, visual impaired people also reaching through the assistive therapy. And scientific impact, LVCP is teleophthalmology experience, including all subspecialties, including telerehabilitation. Lessons learned and experiences have been published. And the journey continues to build the people-centered eye care solutions so that all may see. Thank you.
Thank you, Dr. Padmaja. It was an excellent talk. And I think a learning lesson for all, that how you can translate whatever you have done into some good publications, good evidences. Just one thought, like at Shankanetralaya, what we believe and what we have been practicing, we divide tele-counseling and teleconsultation as two separate things. Because many times the ophthalmology practice, though it is very image intensive branch, but if we are just talking to a patient either by a video call or by just an opinion, we categorize it into telecounseling, and because that's not a complete teleconsultation. However, if we have another way where we can take images and upload, and one of the initiative which was taken by Dr. Sudhir is putting some videos on how to take your own anterior segment pictures very well and uploading it. So I think we must differentiate these two, because teleconsult is a little more complete evaluation. Thanks, and excellent talk. We will go to the next talk by Dr. Kim, who will be sharing the teleophthalmology in a vision center, primary care, how it can be used. Dr. Kim, please.
Thank you, Rajiv. I'll just go directly to the topic of teleophthalmology, how technology is being used in the vision centers. We had started these vision centers about 15 years back, where each of these vision centers covers a population of about 50,000, where there's no ophthalmologist available. These are permanent facilities which functions every day of the week except Sundays, and equipped to provide a comprehensive eye examination for the patient, and is staffed by a trained ophthalmic technician or optometrist, and it provides primary eye care and as a referral service. So what happens? Patient visits a vision center which is available locally. None of them, no patient needs to travel beyond 15 kilometers is what we are planning on. And the registration, after registration, the optometrist does all the eye exam, just like how a doctor would do, slit lamp, IOP, fundus examination, and also a fundus photography. The entire data is uploaded onto the EMR, and the patient is advised.
The slides are not moving.
Sorry.
And also it's not on slideshow.
Oh, I'm sorry. I didn't realize that. Okay, let me try again. Can you see the slides now?
No.
No.
Not yet, sir.
No,
it seems
sir.
as if it is
Open it the
loading.
way you opened it before and just make it in a slideshow.
Like this, right?
So it's open here.
Are you seeing the slide now?
No, not at all. No.
No.
Okay.
You've already shared the screen, but nothing is visible.
Uh-oh. Okay. Maybe I'll stop.
Stop sharing the screen and go back again and start sharing again.
You unshare first.
Stop share now.
Yeah, I did that. And
Now
now
go
I'm
again.
sharing again.
Yeah.
I'm doing the same thing.
It's coming, but no picture is coming.
Uh-oh.
Okay. Already.
No, just wait for a second. Sometime it may start now. You share the whole screen, or rather than putting PowerPoint sharing.
That's what I did, Rajiv. I'm not sure why it's not happening.
It was there. First time it was there.
The way you did before, you do that.
I stopped sharing now.
Yes, the way you started with, you share like that and just put a full screen.
Okay. Can you see now?
No, sir. It has started sharing, but it is not sharing.
Sir, go to basic or advanced, otherwise basic.
No, it's okay. Let Dr. Sheila John start.
Dr. Sheila can start, and sir, you can send an email to me. Attachment, okay. I will open it from here.
Sure.
Dr. Sheila,
yeah.
I think we will have the next talk. So again, it is the same teleophthalmology in the primary care, but you will see two different models. How a teleophthalmology in the primary care is done at Arvind and at Shankar Nethralaya. Dr. Sheila John, please. Dr. Sheila John heads the teleophthalmology unit at Shankar Nethralaya.
Yes.
Can you make it full screen? Yeah, done.
Good evening. My topic today is teleophthalmology in primary care using mobile vans. Healthcare availability in India, population of more than 138 crores resides in India. 80% of the population reside in rural areas. 70% of healthcare resources are in urban areas. One ophthalmologist per 1 lakh population. Shankar Nethralaya Teleophthalmology Mobile Unit was started in 2003 with the help of Indian Space Organization. They provided the satellite connectivity which was mounted on top of the bus. This bus had an examination room inbuilt in the bus where patients could be seen, plus video conferencing unit was also there. So teleconsultations could also be done. But the disadvantage with this was one optometrist was seeing the patients. So only about 30 patients could be seen in a day. So by 2010, we shifted to internet connectivity. We did comprehensive eye examination in rural areas at the patient's doorstep with spectacle dispensing, eye screening for school children, and diabetic retinopathy screening camps. The number of camps were from April 2000 to March 2020 was 1,889 and total patients more than 1,50,000. Here in the bus, we do not have an examination room. This bus carried the paramedical staff and the equipment, and a facility was found in the villages where we could download the equipment and use it. I would like to share a video with you where we are conducting the camp in a rural area. For conducting the camp, the permission of the district binary control is needed, as well as you have to inform the Gram Panchayat person who he will look for a facility or a house which will be provided to conduct the camp. This is a rural village where in the morning, with the help of the Gram Panchayat person, we have collected about 100 patients for examination. They're waiting for the bus to come in. The bus with the paramedical staff and the equipment reaches the campsite. Again, there is no examination room in the bus here. The paramedical staff download all the equipment and set up the facility in the facility given by the Gram Panchayat person. Announcements are made before starting the camp, and demographic details are entered in the electronic medical records. Refraction is done with the help of autorefractor. Then subjective refraction is done, both for distance and near. And if patient has any spectacles, the power is also found out using the lensometer. Again, all the entries are done in the electronic medical records, which is an offline electronic medical record. One acts as a server, the other one entries are made. And once all the entries are done, it is got to the base hospital and uploaded in the server here. It's a completely offline server using a Wi-Fi connection there. Slit lamp examination is done, anterior segment, as well as intraocular pressures are checked with applanation tonometry. Anterior segment images are also uploaded into the electronic medical records. All the findings are recorded. Fundus examination is done. Non-mydriatic, we do not do any dilatation drops. Dark adaptation is done. Again, the fundus images are uploaded into the electronic medical records. Interpupillary distance is taken and glass dispensing is done. Counseling for patients are done. Teleconsultation is done with the optometrist and the patient at the campsite using a laptop and data card. And at the base hospital, the ophthalmologist with the technical assistant is seated. Patient's attender is also counseled regarding whether the patient needs medical or surgical treatment. If surgical treatment, how many days you have to stay in the hospital is also discussed with the attendant. The patients which require cataract surgery are picked up and taken back to the camp. In the particular camp, about 100 patients were seen. Majority had refractive errors where the glasses were done, taken up for the prescriptions, and then cataract was identified. Next, diabetic retinopathy, then all other features. Here again, I would like to mention that Shankar Nethala Base Hospital, the ophthalmologist is seated, and at the campsite, the optometrist with the patient is seated, and the real-time sharing of images happen. We have a mobile refraction unit given by Essilor India, where we hatch an edger there, so it delivers spectacles at the doorsteps of the needy people. We again, Shankar Nethralaya, in combination with IIT Chennai, had done a mobile eye surgical unit. One of the vehicles is a preparatory vehicle, another one is the houses the operation theatre. From December.
Please conclude, your time is up.
Okay, about 10,000 cataracts have been done. Okay, thank you very much. And I would thank the AIOS team and Josie for giving me
Sheila, thanks, Dr. Sheila, for sharing that model. I would now share the slides for Dr. Kim so that he can share the experience of Arvind Eye Care on teleophthalmology for the primary care. Can you see my slides?
Yes.
Thank you, Rajiv.
Yeah.
Can you go down the slides? Yeah.
Yeah.
Next. Next slide. So I was just talking about creating vision centers, which are just primary eye care centers for every 50,000 population. These are permanent facilities equipped to provide primary eye care and is staffed by a trained ophthalmic technician or optometrist, whoever is available. And it provides as a primary care and referral service. Next slide. So what happens in the vision center? The patient gets registered. The optometrist does the complete eye examination as a doctor would do, including slit lamp, IOP, fundus exam with the 90D, and where indicated, they would do a fundus photography. In all diabetic patients, they are asked to take a fundus photography. And then entire data is entered into the electronic medical records, where simultaneously ophthalmologist from the base hospital is looking at the data, and then they get into a teleconsultation mode. Every single patient walking into each of these vision centers get a teleconsultation with the doctor, and based on the need, whether it's glasses or medicines, are dispensed right in the vision center, so the loop is completed. It's seen only 10% of the patients ever seen in the vision center needs to be referred to the base hospital. Next slide. So this is the concept of vision center, where we have a hub and spoke model, where one of the base hospital has multiple other tertiary hospitals have multiple vision centers attached to it. Next slide. So this is one slide. This is supposed to be the best last mile connectivity in any healthcare intervention as of today. And it has access to care for the people in those areas 6 days a week. Since it's locally available, more patients are accessing. And the most important is there's no dependence on attenders for these patients to go and visit a hospital. There's obviously time and money saved. But more importantly, we have found that compliance to care, especially for diabetes, glaucoma, these patients can be followed up much better, and it is the onus of the vision center technician to ensure the continuity of care in these vision centers. So this is next slide. So this has become like we are doing almost 2,000 consultations a day across our 91 vision centers. But more importantly, during this COVID period, we had more consultations than in the base hospitals through these vision centers. And this was really a boon for the people in the remote locations. Next slide. So this is just the numbers. We had in the last 1 year about 4.5 lakh patient visits to these vision centers in the last 1 year during this COVID period. Earlier, it was much higher. Next slide. So it has become a scalable model. Next slide. So with Tripura was the first center where we opened 40 vision centers in 2007. And in the recent times, these are getting replicated by the government of these different states. Recently, Tamil Nadu has planned to start 32 vision centers in Tamil Nadu. Next slide. And Bangladesh is another place where there are major expansion. About 400 vision centers are being established with our help. The first 90 has been started, and this is becoming a real good way of reaching the patient in the remote locations. So I'll stop here. I won't go ahead with further in the interest of time. Oh, I'm sorry. I should mention the LVPI and the model. The LVPI had started this primary. I mean, they were starting the first vision centers, and then recently they've started integrating it with the technology. And so patients are examined by vision technicians, and teleconsultation referral is based on specific guidelines which they've interpreted, and using integrated medical records, they are able to advise the patients accordingly. So there are a lot of attempts that they are doing to improve the diagnosis in these vision centers. So these are the numbers. I will stop here in the interest of time. Thank you.
Thank you, Dr. Kim. Great insight into how teleophthalmology has spread across not only India, but other countries too. We will have the next talk. So we have heard how it is paving way into primary care, but everybody is bothered how we can create a business model in teleophthalmology. And Dr. Senthil, who has successfully done that, would be sharing with us his experience. Dr. Senthil, please.
Yeah, thank you, Dr. Raju. Initially, the session started with 8 minutes. Now I think the time is 4 minutes. Even before I get started, I think the time might get over. So I maybe next time I would suggest that it should not be like a race against time, because we cannot tell what we want to tell. So if, I think that has to be, maybe it reduce the number of speakers. So let me try to do, because I'm just focusing on the time more than the presentation.
No, don't worry. You
Please
continue. You continue. Nobody will stop you, please.
No. The audiovisual will stop at 5:25. Sorry, audiovisual will stop at 5:25.
Basically.
Please continue. Yeah.
So all the previous speakers, Orbis and Shankar Metralia, LVP, and so all of them spoke about the different models they have implemented. So by the meaning of business model, what we mean is, one thing is creating a viable financial model, and the second thing is an executional model. So basically, the difference between market takers and market makers is in the product innovation. So in teleophthalmology, there is one side you see a huge product innovation in terms of fundus cameras, but what I feel is more important is a viable business model innovation. More and more private players coming in, more and more revenue being generated. I think that is when these models will definitely scale up. In the next 2 minutes, let me try to rush through what are the different models available. I think Dr. Padmaja spoke about the telemedicine practice guidelines. So there are 6 or 7 business models. One of the main model which became more prominent during COVID is the direct-to-patient teleconsultation, where patients started directly talking with doctors. There was a huge spike in the direct-to-patient teleconsultation, but as we all know in ophthalmology, it is not only a teleconsultation where you speak with the patient, but you also need this investigative devices. You need to look at the visual acuity, the anterior segment image and everything. So as Dr. Rajiv said, this could be called telecounseling rather than a teleconsultation. It was good to do the initial thing or maybe give a second opinion, but this kind of a model didn't scale up, or it became lesser once this COVID, once eye hospitals started opening up. I see there is a huge opportunity in a healthcare facility model, like Dr. Kim has said, where patients go to a vision center which is equipped with a fundus camera, equipped with a slit lamp, or maybe even an optical shop. I think this model where there is a technician who can capture the basic patient information and then share it to an ophthalmologist, providing access to ophthalmologist. I think this model is something which will scale up. And Shankar Metralia, through the mobile van, they have this teleophthalmology where the vans go into the community and do the screening. One of the most economically and financially successful models is the diabetic retinopathy screening model, where it's just like teleradiology, where patients' fundus images are captured in diabetes centers, and these images are uploaded into the platform, and then ophthalmologists doing the reporting. So this is one of the most viable model, though this model has its own challenges. One thing being the cost of the instrument, and then acceptability of patients and the diabetologist. But still, I feel one of the most interesting revenue generating models which is scaled up in ophthalmology is the retinopathy screening model. And there is the model where you screen for ROP using devices into the neonatal ICUs. Equipment cost is again a constraint, but I think this is something which we can look into. And there are companies which are now coming with this vision checkup kiosk kind of a model. Just 30 seconds, I'll finish it. So the kiosk where patient gets into a globe thing of a kiosk, and then you have all these equipments inside, and then it's remotely connected to the ophthalmologist. This model is also picking up. Vision checkup kiosk placed in railway stations or placed in malls, where patient himself can do the visual acuity and basic eye testing. this is also catching up now. I think there's a huge opportunity in teleoptometry, because in a country like India, where you don't have a trained optometrist, where this optometry process can be controlled by an external optometrist from a central location, I think huge opportunity in teleoptometry. And there are lots of these vision testing devices where patient can themselves check up their visual acuity at home. IQ is one company which has come up with this device. Online visual field testing can be done either in patient's home or in clinics, very low cost for glaucoma and visual field testing. And the imaging devices have to be coming at lower cost for these models to scale. And a huge hype about artificial intelligence, a lot of companies doing it, but the revenue generating model is not yet established. Hopefully in the next 5-10 years, these might come up. And these are the fundus cameras. This is something about our company. So we have actually created a viable model where we scaled up all over India. And I'm finishing. Thank you.
Thanks, Dr. Senthil. I think a lot of things to learn, and I'm sure you rightly said small, short time, very difficult to convey, but you have conveyed the message. I would request Dr. Abhishek Sajdeva. He'll be talking to us on why teleophthalmology in your early practice days. So it's not like a senior person only should do. In your early practice days, why you should take teleophthalmology, Dr. Sajdeva will tell us.
Yes. So this,
yeah, screen is seen. You can make it full screen.
Yes.
Yeah.
I'll just try to rush. Good evening, everyone. So I want to discuss on why teleophthalmology in early practice days is also very important nowadays. So I have no financial interest, and special thanks to Dr. Sheila John and all the other 2C members. So telemedicine has the potential to transform ophthalmology because of the multiple technological advances that have come up, and more and affordable, accessible healthcare that has been coming up, and gradual expansion of reimbursement for telemedicine services, and government formulated guidelines for practice of telemedicine. So now there are a very positive change in attitude of doctors is also being seen. Doctors are becoming more familiar with growing variety of applications and services using two-way video, email, smartphones, wireless. Doctors needs to know about digital imaging and communication in medicine, standards and compliance, data security and hardware and software for telemedicine, and government protocols for quality information to make ocular diagnosis also coming up. So a significant, there are lot many significant challenges that we still face. While there may be some reluctance to embrace telemedicine. I think most ophthalmologists do understand that this is headed their way and they need to be prepared. Teleophthalmology interferes with the classic pattern of physician's physical examination and interaction with patient, and the in-person empathy shared between them, and it needs innovation and early adoption. So the mobile health checkup, online SMS-based consultancy over symptoms and clinical advice, teleconsultation done in geographical areas where 3G or 4G network is available. iPhone is attached to a direct ophthalmoscope to record fundus images. So like AI integrated telemedicine platform, or the cataract artificial intelligence integrated telemedicine platform for deep learning for training. And as we are all aware nowadays, tele-education, so everybody is having these online classes and conferences. So I think this will grow in further years, and webcasting and on-demand videos. And because of this COVID thing, so this is becoming more useful, because teleophthalmological practices personal safety both for the doctors as well as for the patient. But I feel telemedicine cannot be the answer for all the problems, but it certainly can be very important in addressing vast array of problems. So we have traveled some distance, but still a lot has to be traveled. Still a lot has to be covered with obstacles like technology and laws, but no road is long with good company, and I strongly feel TOSI is that company. Thank you.
Great.
Thank you, sir.
So nice.
I would like now the last speaker, before we have a little discussion if we have time, Dr. Ritika Sajdev. She'll be sharing her thoughts on teleophthalmology. Is it a boon or a bane? Dr. Ritika.
Thank you, sir. Is my screen visible?
Yes.
I'll just be taking you over 1 minute or so, just some cases. As an individual practitioner, we also have a liability. Of course, we at Center for Sight have the backing of an institution, but I just want to have some take-home messages for the individual practitioner. Is the video visible?
Yes.
Okay, so this is a patient of mine who basically complained of red eye. 5 years ago, I had done intacs for this patient. And we all know vernal keratoconjunctivitis is a common feature in keratoconus. During the first lockdown, he reached out to us for teleconsults. We had also made our videos about how to photograph the eye. So you see, he has actually sent beautiful pictures of the eye. And he had a red eye. So we basis the pictures, treated him with a diluted, a low-dose steroid and antibiotic combination. He did not get better. And 10 days later, when he came to the clinic, there was actually a large area of stromal lysis or stromal melting that had happened over the intact segment. Once this comes in, it's very difficult to get this cycle broken, and the intact segment actually has to be explanted. So what we are doing here is explanting the intact segment. The take-home message is a simple red eye with a good photographic documentation. Also, sometimes there is more to it. And therefore, I think the concept that a lot of institutions, including ours, has adopted is that of assisted teleconsult, wherein a home visit or a vision center model may allow better documentation. Had we used fluorescein stain or possibly an optometrist taking the photograph, we would have gotten into a better position. So moving on to the next case, this is another red eye I'll be taking you through. Now, this is the next patient is also a red eye being treated at our hospital for uveitis and had corneal opacity, possibly keratouveitis. Again, gave us a photo of the eye. It was red and there was the corneal scar was visible. We counseled the patient that it would be better that she comes to the hospital, and we would not want to prescribe steroids over a teleconsult, and ended it as a telecounseling. Of course, the patient did not come to the hospital and self-medicated with steroids, and as a result got a secondary fungal infection. By the time she came to the hospital, the fungal infection had spread, and you can see we had to glue it, but it was an unrelenting course, and eventually a patient would need a therapeutic keratoplasty. So all I'm trying to highlight is teleconsult is a great tool, but sometimes despite the best pictures, an examination is not complete. And though we live in COVID times, in normal times, along with COVID times, it will come with its own liabilities. So please understand this technology, along with the pearls, it comes with pitfalls. Thank you for your attention.
Thanks, Dr. Ritika. It's a really important lesson which you have given to all. It's many times it's not this WhatsApp consult or just seeing the images. You cannot really make a diagnosis. Thank you very much. I think we are at the end of the session, and I would request Dr. Subudhi if he wants to give some concluding remarks. I don't think we'll be able to do any panel discussion.
Yeah, I think the time is constraint. Already the bell is ringing. So in the end, I would like to conclude with. Yeah, okay. Half minute. So it's a very good, excellent program, but somehow the time was a constraint and the time is very much limited. I thank all the speakers who have contributed to this program today, including our international speaker, Dr. Hunter. So it was really wonderful to learn something about the Cybersight, and I think all will be utilizing the Cybersight to learn more. And thanks, Dr. Raji, to moderate in a very brief time, and somehow we could not give much time to the speakers, and some discussion was missing. But however, this is the beginning, it is not the end. So it has got a lot of future for the teleophthalmology, and we will be looking all of you in future once again. So thank you all. Let us join.
Just one point I would add. Please. I think it's all of you who are watching this. There is a new society which has been formed, the Teleophthalmology Society of India, and I'll urge all of you, because COVID is not to go. We all have to practice teleophthalmology. I would urge all of you to become member of TOSI.
Thank you.